Everyone, good morning. And then this is Tong from Jeffern, and welcome to join our live webinar for today. So, because we're gonna have our World Sepsis Day tomorrow, so by the chance, especially today, we invited dear Professor Ranko, and then Prof. Otai and Dr. Fernando and Dr. Sarah from different countries. They are quite experienced in the intensive care units, and then with heaps of experience of using our hemoabsorption cartridges. So you can see from my screen, for a sec. So today's webinar's agenda is including the topics shown on the screen. So first of all, we invited our Professor Claudio Ranco to give us a speech, opening speech. And then later we invited Professor Otai and Dr. Fernando to give them presentations. And then later we'll follow up with the discussion Q&A, and then here we specially invited Dr. Sarah from Italy as well to join in the speech and discussions. And then later I'll do a very quick sum up. And then, so because today we are very honored to invite Professor Claudio Rancourt as a moderator for this webinar. So as you can see from the screen, Prof. Claudio Ranco, he is the director of the International Renal Research Institute of Vicenza, and then he's also the professor of medicine, University of Padova, and then he is a globally recognized pioneer in critical care nephrology, CRRT, PD, and cardiorenal syndromes, and artificial kidney technology, and he's very, very experienced in the hemoabsorption area as well. So now let's just welcome Prof. Ranko to give us a speech. And then Prof, you might start sharing with your screen, and then I will start from here. Thank you.
Okay, so thank you very much. Let me share my screen. All right. Can you see my screen? No.
Yes, that's fine. No problem. Yes. You can see.
Can you see it?
Yes.
Okay, excellent. So first of all, I would like to thank Jaffron for inviting me to be a moderator and speaker at this meeting webinar on sepsis and hemoabsorption therapy. I think the time for this webinar is the right one because there is emerging evidence that hemoabsorption can be the technique of choice in case of sepsis. And we have recent results from clinical trials suggesting this concept. Now, why do we want to have an extracorporeal therapy for sepsis? Well, the reason is that, first of all, most of the pharmacological trials have failed to demonstrate any effect of a specific pharmacological agent. The second point is that indeed there is a rationale for presence in blood of septic patients of substances that may have a causative effect on the vascular tone, on the general immunodysregulation, and on the final organ damage. So the point is that I think we need to collect experience from all over the world. And today we are fortunate enough to have Professor Oktay Demi-Kran, Fernando Sanchez Moran, and Sara Sant'Ambrogio. I think that these colleagues will fill the webinar with important information about using hemoperfusion, hemoabsorption in critical care, and specifically in sepsis. Now, considering the aspect related to sepsis itself, I think that there is clear condition that in over the overall population, we have specific phenotypes. Phenotypes in which we have a documented infection, phenotypes in which we characterize a cytokine release syndrome, which is the so-called the tornado of dumps and pumps molecules that may end up with organ damage. And finally, subjects with impending organ dysfunction called, for example, sepsis-associated AKI. Now, based on this, we know very well that previous trials on pharmacological agents and also in some cases on extracorporeal therapies have failed because the population studied was absolutely, let's say, non-defined, and the heterogeneity of the population has created problems in determining the response to therapy. As a matter of fact, we may have a positive, neutral, or even negative response. But this reason is important to consider in the light that we have different phenotypes, and finally we have different endotypes where we can also analyze the pathophysiological mechanism that leads to the septic phenotype. At this point, once we know the endotype of the patient, we can definitely address the therapy and describe the concept that extracorporeal therapies are not for every patient, but only for a specific patient, and therefore enriched population trials should be considered today in order to perceive the efficacy, efficiency, and safety of hemoabsorption. I have reported in this slide the fact that, as you can see here, you end up with different endotypes. And if you have microbiological agent present in blood with positive hemoculture, of course, antibiotics, but also new extracorporeal therapies removing viral particles or bacteria can be indicated. If you have endotoxin activity assay that is between 0.6 and 0.9, we have clarified also with the recent results of the Tigris trial that absorption of endotoxin by hemoperfusion devices can become the crucial approach. And finally, when you have oliguria, hypotension, stress AKI detected by biomarkers, I think that this is the typical patient in which organ damage has not occurred yet, but you might need to consider hemoabsorption to prevent and protect the organ. The same is true when AKI develops, a patient is oliguric, hypotensive, and finally when you have AKI. But in this case, I would like to focus specifically on the early application of hemoabsorption. So once you have define the indication, I would say it's very important to start with different points throughout the therapy. And therefore, first of all, after you endotype your patient, you may decide the timing of starting and the timing of stop. And as I mentioned before, I am in favor of starting early in order to prevent the deleterious effect of the immunodysregulation and pumps and dumps. Concerning device techniques, I think that this can be hemoabsorption can be utilized as isolated technique or in combination with CRRT. And this actually is quite simple to make, because the addition of the cartridge to an extracorporeal circuit is definitely simple and completely free of mechanical or technical complication. The other question is session duration. Session duration is a very important concept because the maximum efficiency of the cartridges available today is probably in the first 6 hours of use. We can probably go up to 12 hours, but makes no sense, in my opinion, to utilize a cartridge for 24 hours because the absorption capacity is completely, let's say, reduced. Therefore, next step is to consider frequency. And it is probably better if you start early to consider 2 sessions in the same day, possibly 4 to 6 hours each. And in the subsequent days, also, you may decide the frequency. But again, this has an important, let's say, aspect concerning the efficiency and the efficacy of the treatment in the patient. And finally, monitoring is quintessential because in the studies that you do, you might have different targets. One, you may have a biochemical target, and this is important if you decide to monitor specific molecules. Then you can have a biological target, and this is in case you decide to monitor, for example, immunofunction like HLA-DR expression or apoptosis or other specific biological effects on cell and tissues. Then you might have specific physiological endpoints that consider specifically blood pressure control, response to the infection, temperature, white cell count, etc. Then you have clinical response that in most of the cases are documented by SOFA scores and level of organ damage. And only ultimately you will consider mortality because we have seen that, especially in the Tigris study, that mortality at 90 days may be an important target to consider, since today critical care management can definitely keep alive a patient for the very first 30 days. So today, I'd like to point out that while in the past with the Jafron cartridges, we have been focusing on the let's say DAMPs molecule, which is mostly cytokines, as you can see here. Very recently, we were able to evaluate the new CA cartridge that is also capable of removing LPS, as documented by LPS measurement and endotoxin activity assay. So in my approach to sepsis, I think that the very early approach should be done with the CA cartridge that removes pathogen, endotoxin, and potentially cytokines, followed by cytokine removing devices such as the HA380. And only when you reach organ failure, you may decide to utilize organ support with other techniques. About the frequency, I think that I mentioned the early application importance. And therefore, this is basically the regime that I suggest for a septic patient, which is one treatment with CA for 4 hours, maximum 6 hours, and then one treatment within 24 hours with an HA380, and then followed, if needed, by one treatment and one treatment in the following days. Again, your endpoints should guide your prescription and monitor the patient. So with this, I would like to stop what I have presented here. And of course, I would like to ask now the group of speakers to follow. And Tonton, can you please translate my presentation into the next slide transition, in which I present Professor Oktay Demirgan. Can you do that?
Yeah, of course. Just give me a second. Thank you so much, Prof, to give us a wonderful opening speech. And then I just gonna scroll down.
Okay. So Professor Oktay from Turkey is professor of Istanbul University, Ceylanfasa Medical School, director of the Department of Anesthesiology and Intensive Care with expertise in cardiopulmonary resuscitation, sepsis and septic shock, and the management of critically ill patients, president of Department of Intensive Care, Ceylanfasa, and board member of the European Sepsis Alliance. I would like to stress the concept that critical care in Turkey was a discipline founded by Professor Cemalettin Oner, which I had the pleasure to meet several years ago, and then was followed by a good friend, Kutay Akpir, in Istanbul. And so now we have let's say a new star in the Turkish critical care that will tell us about his experience on and practice of hemoperfusion and hemoabsorption in critical care.
Everyone, thank you very much to Jeffrey for inviting me with this special webinar, and Professor Ronco, thank you very much for your introduction. And I am the former president of Turkish Society, past president of Turkish Society of Intensive Care, and the Sepsis Day has a very big effect in our country, and tomorrow we have also a very important meeting for this World Sepsis Day. Also, whole week, we will do some meetings in our country. And now I will talk about the hemoperfusion, which is important in septic patients, and we use it a little bit theory and practice in critical care area. And for that, the idea for the extracorporeal blood purification to eliminate injury is important. Blood purification techniques such as hemoadsorption are widely used now, and the clinical practice is very important. And the theoretical rationale, and despite lack of clear evidence, is important here. And the critical ill patients has several challenges, which are they are in multiple organ involvement and in complex clinical conditions, and there is increasing in the incidence of sepsis, and there's unmet diagnostic and therapeutical needs in that cases in that patients. And there are some new areas of research like biomaterials, the applied nanotechnology, new devices, new sorbents and membranes, and transition from diffusion convection to absorption is another part now which we use in our clinical practice. And the new frontier in extracorporeal perfusion hemoadsorption is we use the solute mass separation may occur by some barriers like membrane or solute agents, sorbents. And there are two parts before diffusion and convection. Diffusion to remove small solutes like in hemodialysis, which is inefficient molecules over 3 kilodalton, and convection to remove middle molecules up to 10 kilodalton, and using ultrafiltration and solvent drug. The most modern membranes cannot effectively remove uremic toxins and septic mediators with molecular weight is over 10 or 15 kilodalton. There is a problem, and because of that, we need a new and interesting option, which is hematsorption, to overcome the limitations of dialysis techniques and providing the required removal of large middle molecules, which has helped us now. And I will talk a little bit about the evolution of the sorbents. The hematsorption implies direct contact of blood or plasma with a sorbent. For this to occur safely, a sufficient level of biocompatibility is needed in that cases. The sorbents can be natural, which is zeolites and porous carbons, and synthetic polymers. The sorbents, which are natural zeolites and porocarbons, are low biocompatibility, and they had serious complications because of sometimes they had the problems which is in clinical use. And recently, now we have synthetic polymers chemically modified to become more biocompatible and which we can use it easily. And if you look at the development of the sorbents in extracorporeal perfusion here, it was started in 1850, and now nowadays we use the new clinical applications and development in neutral microporous resin optimized by advanced surface coating and nanoscale molecular sieve control technology. The sorbent materials, which are zeolites, are inorganic porous, and other typical sorbents such as porous carbons are cellulose derivative organic polymers prepared by controlled thermal oxidation. And the synthetics are different polymers of synthetic origin. Almost all polymerizable monomers can be built up into large molecules via a multitude of reactions. And the vinyl benzene is generally used as a potent cross-linker here, and it can also exist in forms of granules or fibers that are functionalized with specific substances. And the sorbents, if you look at the sorbents material, they are existing granules, spheres, cylindrical pellets, flakes, or powder. Depends on the material which you use in your daily practice. The pore density and the pore size distribution in different polymeric resins are important, and you can see here there is a long, wide absorption capacity here. Start from urea till to albumin, which is 50 nano nm, and there are microporous, mesoporous, or macroporous pore sizes which are effective for absorption. And there are some important points that for safe and effective sorbent therapy, it must be effective and hemocompatible sorbent material, and design sorbent cartridge, which is important, and also it's important to use it easily, and it must be simple implementation of related techniques. No or negligible side effects. The side effects is very important for our use in clinical practice. The requirements for sorbents are important, which are biocompatibility. You can see here free-flowing tendency, no falling tendency, adequate porosity, affinity and selectivity is important. The chemical stability is also important. The thermal stability and mechanical strength are very important parts of a sorbent. And the modern sorbents are derived from polymers that create a pore structure. The current sorbents effectively remove the molecules between 10 to 15 kilodalton, which are cytokines, chemokines, protein bonds, solutes may be removed. And the porosity is regulated by the manufacturer, making it possible to target for the specific molecules. You can see here different sorbent beads in electron microscopy, three-dimensional sponge-like structure here. Very, very interesting and important point here from 10 to 50 nm porousness and sorbents. The absorption mechanisms and the chemical, physical forces are also important. There are some different mechanisms to regulating molecular surface absorption, which are van der Waals forces, ionic bonds, or hydrophobic bonds are important to make it stable and effective. The biocompatibility is very, very important point that to the flow of the fluid phase, the blood inside the sorbent cartridge, it can be inter, extra, or intraparticle, which is governed by Darcy laws and the Carmen-Cosenzi equation. The size of the beads, the porosity, packing density, the length of the diameter of the unit, the path of the tortoise, and the Reynolds number is important in that use. You can see here the interparticle flow, extra particle, the surface flow here, and interparticle flow. The maximum extent of absorption occurs when the equilibrium is reached, is isotherm effective in that cartridge. This is an interesting research here. There is a flow distribution analysis by helical scanning inside the sorbent cartridge. HA380. You see here the distribution of the dye injected during the blood flow, and the circulation describes a homogeneous pathway with complete exposure of the available sorbent to the fluid phase. The fluid phase is the blood, we call it. The rationale for hemadsorption is high level of harmful molecules in blood are observed, and in the case of kidney or liver failure, we can see in the intensive care easily these cases, and in the case of exogenous intoxication, and correlate with the severity of the disease and mortality. And the basis of life-saving treatments is external blood purification. And the use of hemadsorption in several clinical conditions in intensive care. We have part of renal in ICU, liver part, or intoxication. In renal part, we can remove the middle, large, or protein-bound uremic toxins, and we can use in sepsis-associated AKI, renal protection. In ICU treatment for critical illness derived from cytokine release syndrome, for hemodynamic stabilization, for organ protection. In liver, for high bilirubin levels, in severe hepatitis, liver failure, and decompensated cirrhosis or intoxication, and for kidney and liver protection to reduce severity of illness and shorten the hospitalization. And the rationale for hemadsorption is the varying pore sizes so that molecules can be separated from each other based upon the size, geometry, and individual binding proteins are important parts. And the maximum extent of the absorption occurs when the equilibrium is reached. Absorption isotherm can be used to determine the amount of the sorbent required to remove a given amount of the solid from the solvent is important point. In the Jaffrand Biomedical Company developed a series of new sorbent materials which are included neutral microporous resin with capability to remove the molecules in the range between 10 to 60 kilodalton by absorption, and a special coating and a non-controlled prescription of the coating film on the surface of the beads allow an excellent hemocompatibility and free flowing tendency of blood in the interparticle space. And also the cartridges of the Jaffrand hemoperfusion of the neutral macroporous resin type. The beads are made of styrene divinyl benzene copolymers and carry a mean diameter of 0.8 with a range from 0.6 to 1.18 mm. The pore sizes, the size of these coated beads and the volume of the cartridge and the packet resin vary according to the type of the cartridge which we use, and from smaller pore sizes with HA130 cartridge and to large sizes to A330 or A380 cartridges. If we check the 880 and 830, the cartridge packages has significantly greater amount of sorbent in 830 and 380 and the volume versus 330. The small cartridge volume has in 380 145 ml. You can see the different size and kind of the cartridges here, Jafran cartridges, which we use in different purposes in the ICU. They have neutral microporous resin and styrene divinyl benzene copolymers. And different characteristic for 330 and 380 Jafran cartridges. The sorbent volume is different, and the sorbent material is same. The housing material is same, and the volume is different between 380 and 330. And there are hematsorption, which look at generally selective and non-selective hematsorption materials. In sepsis, two approaches have been suggested that to use a selective target of key molecule like endotoxin and non-selective broad molecular spectrum adsorption for sepsis. The adsorption techniques and indications are important. We use in sepsis and other cytokine release syndromes, in intoxications and poisoning, and the general applied for repeated sessions for 6 to 12 hours each with a blood flow and 100 to 300 ml per minute. And sometimes we use the plasma filtration and adsorption to remove the bile acids and other protein-bound solutes in acute liver failure and or in decompensated cirrhosis, and the plasma filtration in the extracorporeal circuit. The filtered plasma processed through a sorbent cartridge in subsequently re-infused in the venous bloodline and reconstituted in a whole blood. And sometimes we combine the techniques hematsorption and CRRT when there is sepsis-associated AKI to remove the cytokines and uremic toxins together, and combines the sorbent cartridge in series with CRRT filter. To complete the saturation of the sorbent occurs between 6 and 12 hours. You see here the patient inlet, the hemoperfusion cartridge. If we use only for sepsis for cytokine removal, and sometimes we use the dialyzer plus CRRT and hemoperfusion together. And also plasma filtration and absorption to remove the bilirubin, bile acids, and other protein-bound solutes in acute liver failure or decompensated cirrhosis. And the filtered the plasma processed through a sorbent cartridge is subsequently re-infused in the venous bloodline, reconstituting the whole blood. And also we use plasma filtration plus CRRT to remove the bilirubin, uremic toxins in patients with combined liver and kidney failure. Also, double plasma filtration and molecular absorption system DPMAS. This technique, which we use, is kinds of techniques which we use in hemoperfusion, hemaabsorption plus CRRT, plasma filtration absorption, plasma filtration absorption plus CRRT, or DPMAS, double plasma filtration and molecular absorption system. There are some limitations of hematsorption, which are sometimes controversial results due to the heterogeneity, and both sepsis and sepsis-associated AKI are a mixture syndrome, and they need response of the host play an important role in creating specific endotypes and characteristic in clinical picture, and we have to solve them together. And many problems sometimes we have, like hemodynamic instability, in variations in temperature and leukocyte or platelet count, and sometimes microthrombotic or microangiopathic profiles and oliguria. And we have to solve them. The possibility of measuring endotoxin using a specific assay sometimes it's important, but we couldn't do it clinically, and sometimes clinicians think about that to make it, and before do the hematsorption, we have to maybe think about that. And we have to find the right patient at the right time, which is very important for hematsorption. And hematsorption can be combined with CRRT if immune modulation or cytokines removal beyond renal support is desired. And sepsis and AKI are multifactorial syndromes, and only when presenting in a specific endotype, and there is a rationale for application therapies, even in the absence of any other renal replacement therapy. The right patient, you can see here different kind of clinical scenarios we can use hematsorption here. And they are ARDS, pancreatitis, sepsis, hematsorption, burns, trauma, and there are some pro-inflammatory mediators, and we have to fight with the cytokines, hematsorption need in that cases, and we can use it to prevent any trigger of the organ failure. The trials are very important for the hematsorption, and sometimes we think about the evidence, and every small brick represents an addition to current knowledge is important. Now we have some case reports which are helpful for our clinical practice to use it. We need, for stronger hematsorption therapies, built registries and well-designed multi-center randomized controlled trials, which is not easy to do it now, but with intoxication, poisoning, and drug overdose, and studies report information concerning clearance and mass when the solvents are used in isolation or in series with continuous hemodialysis. And extraction rates vary from 20 to 90%, and there is limited information on the use of hematsorption and plasma filtration absorption with severe liver failure. And few studies confirm the utility of DPMAS in comparison to plasma exchange, but it will increase when we use. And in intensive care, HA330 has been most extensively used cartridge now, but the cartridge has been studied in animal models of ARDS, where it improved oxygenation, reduced the circulating markers of inflammation, and attenuated the degree of injury in the studies previously. And another study in ARDS, 44 patient study, the addition of the cartridge improved the hemodynamics, shortened the ICU stay, and decreased the ICU mortality. Good results. small cases, a small study patients, but good results. The same group of investigators reported an additional data with the 46 patients with acute lung injury in the setting of extrapulmonary sepsis. And treatment with the HA330 cartridge associated with improved hemodynamics, decreased duration of mechanical ventilation, decreased duration of continuous renal replacement therapy, and decreased mortality of 28 days. And here in this study with Huang Zhao, the effect of extrapulmonary sepsis-induced acute lung injury hemoperfusion with neutral microporous resin column with the usual care, the treatment, and here the SOFA score changes and Apache 2 score are same in these cases, and they show that good results with the use of the hemadsorption in these cases. And the effect of pulmonary sepsis induced hemoperfusion with neutral microporous resin, you see here daily the dopamine and noradrenaline used has been decreased. Extrapulmonary sepsis-induced acute lung injury by hemoperfusion with neutral microporous resin, you see here ICU mortality decreased in hemadsorption group, and 28 mortality here has difference in the hemadsorption group. And these two study compared the same study group, different years, randomized controlled trials. In comparison, they have good results with hemadsorption. And you see that in clinical practice, we use this material very effectively in different cases. And here are many studies, and I want to show very shortly, brief time, our clinical cases here, and I will conclude it. This is one of our case with 31 years old after bariatric surgery, very severe septic shock patient, which we use hemadsorption in that case. First time she was cured, and 1 week again she had the second attack of sepsis. We used again the hemadsorption, and you see here the need for the hemodynamic decreased, noradrenaline level decreased, mean arterial pressure increased, and she was well cured. Another case in an intra-abdominal sepsis we used, and we had good results with intra-abdominal sepsis use with our patient. And here we use an interesting also for interesting intoxication with olanzapine and apiperazole poisoning hemoperfusion in our cases, and very good results in our patient. Also, this is an interesting case which we use in a patient with endocarditis, and before the operation we had very good results, and we sent the patient with the infection has been controlled, and he had very good results after the hemoperfusion. Okay, now I want to come to a conclusion. This is very important, and which I said that it's like a domino effect. Once the first stone falls, it's hard to stop. Because of that, we have to think very earlier and at the right time when we decided to use the hemoperfusion for our cases. And do not need to be a superhero. Just think about the hemoperfusion, hemadsorption, and it's a salvage and rescue therapy at the right time, right patient, right screening methods. You can help with the patient, and hemadsorption presents new frontier for extracorporeal blood purification and demonstrated effective extraction of a variety of toxins and drugs during the episodes of sepsis, acute kidney injury, or intoxication. Thank you very much.
I'll move to the next speech. Fernando Sanchez Morano as to present from Spain. Is a director of Intensive Care Unit, General University Hospital, Castellón, Spain, and professor of emergencies in critical care medicine at the University of Castellón, Spain. His expertise is very high in acute kidney injury, renal replacement therapy, and bioethics, end-of-life care in ICU setting. And it's a pleasure to welcome Dr. Fernando.
Thank you very much, Professor. I would like to thank you, Jafron, for organizing this nice meeting. And my topic is about the use of HA380 cartridge in abdominal sepsis, and a small update on current clinical trials and on this pathology. Just to give a quick scope about the definition and the context of these therapies, sepsis is an organ dysfunction caused by a dysregulated host immune response, and despite all the advances we have reached during the last decades, sepsis is still having a high mortality, and the specific therapies are very limited in this setting. So it sounds logic to look for new supported therapies and strategies in this setting. And as we have been mentioning before, there's a strong rationale for the usage of extracorporeal blood purification therapies in sepsis, because theoretically we are able to remove inflammatory mediators such as cytokines and endotoxins, for example. We aim with these therapies to control the organ crosstalk during multi-organ dysfunction, and with these therapies we are giving an additional support to conventional therapies such as antibiotics or vasopressor that still being the base of this pathology. Regarding all this, the clinical evidence is heterogeneous and often offers inconclusive results about imabsorption in sepsis. We have seen in some studies and small clinical series benefits in hemodynamics and some organ support parameters, but the results of large clinical trials show no clear benefit on reduction in mortality. Perhaps we've been focusing in some biomarkers that we know that by its kinetics, they are going to normalize during the evolution of the illness. But despite this, it sounds logic to reduce some of these biomarkers to improve the results of these patients. We know there are many limitations with imabsorption. The population of the study is very heterogeneous. There's a wide variability regarding dosing and timing of initiation of imabsorption. And also we know that this therapy may interact or affect the levels of certain antibiotics, and it's something that we should study carefully. So with all these limitations and the evidence that we have obtained from clinical trials, the future probably goes through a personalized treatments, the so-called one size fits all. Abandon that kind of mantra. We should look for adaptive trials with real-time biomarkers, and as we have heard before, look for new endpoints probably focusing more in morbidity and quality of life more than in mortality. So current practical recommendations, if we can give any recommendation about this, is to individualize the use of hemoabsorption based on clinical parameters and clinical evolution. It is very important to adjust antibiotic dosing during extracorporeal blood purification therapies and consider always hemodynamic and metabolic parameters to ensure the safety of the therapy and to guide the therapy. There is extensive experience with Jafron cartridges in sepsis. Unfortunately, most of them are small clinical trials or case series. So the evidence that we can obtain from them is very scarce, but it's very useful, and we can see from these experiences in order to advance and have a deeper knowledge about hemoabsorption. What we have learned from clinical trials in abdominal sepsis with hemoabsorption, they have evaluated the impact on inflammatory mediators, organ dysfunction, and patient-centered outcomes, but unfortunately, we haven't reached any conclusion to give a recommendation for this therapy. What we have learned is that it's very important the microbial load. It is very important to reduce the microbial load as soon as we are able, and for this purpose, the early antibiotic treatment and the adequate antibiotic treatment is crucial for this objective. From hemoabsorption therapies in abdominal sepsis, we have learned that not all the patients probably are suitable for this therapy. We know that the endotoxin, the LPS load in blood is not the same in all patients, and not all the patients will benefit from the removing of this pump. Regarding the combined endotoxin and cytokine removal, there is a very interesting trial, randomized clinical trial with 58 adult patients conducted with the FRN LPS device. In this trial, they used two absorption sessions separated by 24 hours with at least 4 hours of duration of the session, and they observed some hemodynamic improvement, respiratory improvement, a decrease in creatinine and the need of renal replacement therapy, improvement in SOFA, and reduction in some biochemical parameters. With cartridges of the HA family, we have some experience with patients with abdominal sepsis. This study is not specifically in abdominal sepsis, but 80% of the patients suffer from this condition. The intervention was hemoabsorption with HI332 cartridge combined with CBB HDF versus CBB HDF alone. The outcomes, they saw that there was a reduction in interleukin 6 and in procalcitonin, reduction of lactate and SOFA, and reduction in norepinephrine doses. Also, they observed an increase in 28-day survival in the combined group of treatment. So, given all this, it sounds logic what Professor Ronco mentioned during in the introduction, to think about a sequential extracorporeal treatment to aiming to treat the whole sequence of the pathophysiology of sepsis. It sounds logic to remove the pathogen load with specific devices, as we saw that the load of the pathogen is one of the main determinants of the response. It also sounds logic to remove endotoxin, as LPS is a well-known mediator in all the cascade of events in sepsis, and of course to reduce cytokines and other dams during the phase of immunodysregulation. I would like to bring here some results of uh, preliminary results of a study we are conducting here in Spain with the help of other colleagues. It's a multi-center randomized clinical trial. The main objective of the study is to evaluate the efficacy and the safety of HA380 cartridge in patients with abdominal sepsis and multi-organ dysfunction syndrome. And as secondary objectives, we aim to study the severity progression, the vasopressor requirements, and the length of stay, both in ICU and hospital. We aim to recruit 48 patients. It's a pilot study, 24 in a control group that will be the standard of care, and 24 in the intervention group that will be the standard of care plus HA380 imabsorption. The inclusion criteria is sepsis according to the criteria of Sepsis 3 Consensus Conference, without response to conventional treatment in a situation of shock, and a surgical source of control within 24 hours, norepinephrine dose over 0.25 micrograms per kilogram a minute after optimization of fluid therapy, or a vasoactive inotropic score over 25. Dysfunction of 2 or more organs with a SOFA score equal or more than 7. Blood lactate over 2 millimoles per liter, procalcitonin over 10 nanograms per milliliter, CRP over 100 milligrams per liter, and a concentration of IL-6 over 2,000 picograms per milliliter. As exclusion criteria, age under 18 or over 80, pregnancy of breastfeeding, terminal illness, platelets under 60,000, pancytopenia, severe coagulopathy, or the use of other imabsorption device. This is the treatment schedule, quite similar to what Professor Ronco suggests during the introduction. And the frequency and number of sessions will be decided and guided by the reduction in vasopressors by at least the 50% of the initial ones, and a decrease in IL-6 levels below 1,000 picograms per milliliter. The CRRT dose, when necessary, it will be or it is adjusted and guided by urea concentration. This is the flow chart. Until now, we have this data before the last patient was included. So currently we have randomized 19 patients, but these results are only for 18. 10 for the interventional arm of the study, and 8 in the conventional treatment. These are the baseline data. The groups are quite similar, except for the severity. Right now, patients from the imabsorption group are more severely ill than the conventional group. We don't know if this is a bias, and our colleagues are considering only the recruitment of these patients if they are if the evolution is not satisfactory, but we hope that this will be corrected with the recruitment of more patients. The intragroup analysis, this is in the group of imabsorption and in the group of conventional treatment, the evolution pre and post-treatment, we saw a positive evolution in both groups regarding the vasopressor requirements. There was a significant reduction in the need of vasopressor in both groups, but the severity progression, it was in favor of the imabsorption group with a reduction of the organ dysfunction. We also found a significant reduction of IL-6 pre and post-treatment in the imabsorption group, and also a significant reduction in lactate and pH in the imabsorption group. And in the intergroup analysis, we only found in this first analysis an improvement of pH in the imabsorption group. Always we have to consider mortality, of course. There are no differences in mortality in both groups, but if we have a look at the observed mortality versus the expected mortality, we found a global reduction of mortality, and focusing in the groups of the study, there's a significant reduction in observed mortality versus expected mortality in the imabsorption group. We don't know if these results they are conditioned by what I mentioned before, with the selection of the patients, or that they are true. That we hope that this will be confirmed when the study is concluded. But we have to be very cautious with these results, as the number of patients recruited currently is very small. There is an absolute risk reduction of 10%, a relative risk reduction of 20%, but these results are inconclusive, as they are not significant. The fragility of the study with this so reduced number of patients is very big. Just one patient to change the result will change the result of the whole study. So we have to be very, very cautious in the analysis of mortality. I would also like to mention a randomized control trial currently going on. It's a study not focusing specifically in abdominal sepsis, but I would like to point the attention for the future in this study, because they are using the combined device to reduce endotoxin and cytokine, the new device of Diaphragm. They have planned to recruit 144 patients and randomize these patients to standard of care versus standard care and CA330 imabsorption. We hope we are willing to see the results, and of course they will for them the best of the results. Just to finish and to take home some message, our results suggest a possible benefit that should be confirmed in large studies. There's insufficient evidence to make any recommendation regarding imabsorption targeting cytokine removal. The decision to initiate imabsorption alone or in combination with other techniques remains based on local practices and individual opinion. Some pathogenic mechanisms of sepsis may justify the use of imabsorption. And finally, the potential benefit of imabsorption should be investigated in carefully designed randomized controlled trials in target population to ensure optimal timing of initiation, duration of the therapy, and defined endpoints. Thank you very much for your attention, and I am open for your questions and discussion. Thank you very much.
Thank you very much, Fernando. And I think that your conclusion is correct, although I must say that in most of the centers of ICU and in the clinical practice, very, very little is really recommended by guidelines and specific procedure, and the evidence for ECMO, for example, is certainly not more compelling compared to the one on hemoabsorption. So the use of hemoabsorption, I think, should be considered to improve the experience, and maybe this become part of the routine as many other treatments, as in the case of CRRT, that were never really validated by an important randomized controlled trials. The use of randomized trials is important, but in some cases simply not feasible. And so we have to keep our eyes open to new therapies. Now, we have still 10 minutes, and we would like to ask Professor Sara Sant'Ambrogio from Ospedale Metropolitano Niguarda Cagran in Milan, which has an extensive experience in critical care and emergency medicine. And we would like to ask her to be the discussant of the two previous presentations, somehow highlighting the importance and take-home messages point, and somehow also making possible criticism so that people can actually walk out from this World Sepsis Day themed webinar with some objective comments. So, Sara, can you please comment?
Yes, so thank you. I would like to thank you, Jaffron and Professor Ronco, to invited me among such distinguished speakers. So both the presentation were very interesting, and I would like to go back to the sepsis definition, which is a life-threatening organ dysfunction caused by a dysregulated host response to infection. In this sentence, there is both the severity of the disease, the organ dysfunction, and that is caused by the host response. And actually, as Professor Oktay mentioned and Professor Ronco before, there are the key concept, the new key concept about different phenotypes in septic patients, which is actually something that came quite recently. So the one size does not fit all. It is essential to understand the mechanism of sepsis and how to treat the syndrome. So hemoabsorption is probably very useful in the hyperactivated patients, but maybe the low flow patients or the low immune system patient are probably be treated either differently or sequentially differently. Again, back to the sepsis definition, it's a response to infection. And so both speakers talk about antibiotics, and especially Dr. Fernando spoke about the importance of the correct dose of antibiotics. So we all know that in treating infections, we have to relate to target to antibiotic drugs monitoring, because we all know that some patient can receive too much of antibiotics and go to have side effects or low antibiotics level that are not sufficient to treat the infection. And the antibiotics removal is a key question during hemoabsorption, because cartridge are so effective in remove the cytokines and some other molecules or drugs that could be harmful. But what happens to antibiotics? So as Dr. Fernando mentioned, the important in assessing the dosage of the antibiotics that we are giving to patient is essential. There are a few studies that has been published even recently about on blood purification in 2025. So a very, very recent paper that addressed to the antibiotics removal by cartridges. There are differences. There are many studies, but none of them are conclusive, because we have to consider that in vivo studies are different from in vitro studies, and even in vivo animal models are not the same as a critically ill patient. So there are a lot to go. But I think that both speakers could, underline the importance of understanding the hemoabsorption and understanding when to use it in different clinical scenarios. Yeah, the main message, the key message we have to take home is the one size does not fit all. That I think it's the key of septic treatment, septic patient treatment. And what about the removal of benefit substances, like, for example, antibiotics? And again, how Professor Ronco mentioned how much a cartridge should last, how many treatment could be offered to a patient. We have to see how fast the cartridge can be saturated and when it stops being useful.
So, Sarah, we have made studies, and we have seen that probably 80 or 90% of saturation occurs within 6 hours. So it makes no sense to me to apply for 24 hours. And also the concept of interrupting the treatment allows you to deliver the right dose of antibiotics in the inter-session time period.
Yeah, and we in our institute, we are currently, thanks to Jaffron's sailing program, we are currently testing exactly the percentage, the removal of antibiotics by the cartridge and the filter itself. So what we are studying is how much antibiotics there is before the cartridge, after the cartridge, and which is before the filter and after the filter. And this we are measuring it at time 0, so at the beginning of the treatment and after 4, 8, and 12 hours, to see how much antibiotics is removed. Now there are papers that are suggesting to increase the antibiotic dosage before starting the CRRT and the hemoabsorption therapy, so not to undertreat the patient.
Yeah, my impression, however, is that antibiotic removal should not be considered a contraindication to the application of hemoabsorption, but rather we need to know exactly what happened so that we can take the necessary countermeasures. Increasing the dose of antibiotic is one thing, or making a short session of 4 hours of hemoabsorption and afterwards delivering the right dose, as we do for classic dialysis patients, for example, where we always deliver the drug after the dialysis session, could be the solution. But in any case, I think that there is a major point I would like you to comment, which is in many ICUs, some people are not convinced about using hemoabsorption, but even if they start using hemoabsorption, often they start too late. So what do you think about?
Well, thanks for the question. Actually, it's a very important one. There was a very recent paper by Dr. Bottari in Clinical Care in 2024, and it's important when we go to sepsis and to septic shock, we know that treatment and time is crucial, even for start antibiotics and also for starting any other therapy. So the main treatment, the key treatment, are source control and antibiotics. But if we decide to start chemotherapy, hemoabsorption, this should be done very early. And Dr. Butari suggests within the first 12 hours. So if we treat it, we have to treat it well and soon. And we have to find the patient that should benefit the most from the hemoabsorption technique. So as soon as we have a septic shock patient with a phenotype of activated cytokine storm, that is the time to start the treatment.
We have a question on the best possible strategy to minimize the risk of clotting during treatment.
Well, the regional anticoagulation with citrate is proved to be safe and safe even for severely ill patient, even for liver failure patient. The citrate regional anticoagulation is safe. So we actually are using citrate. We are not using systemic anticoagulation.
I have to say that we also use, in case of need, heparin, and in other patients, in some patients with very high risk of hemorrhagic complication, we even use the system without any anticoagulation, optimizing the flow. So there are several different options that you have to adjust based on the typical patient. Now, in the interest of time, we have to end up at the right moment. I would like to ask Professor Oktay to make one sentence for the World Sepsis Day and the hemoabsorption application.
Thank you very much, Professor Ronco. The Sepsis Day is very important day. We have to aware about sepsis in all of the world, and we have to keep our patient before severe condition. And as I told before, the right time, right patient is very important to start hemoabsorption, and the technique is very, very effective when you use it correctly. And my sentence is that it's like a domino effect, as I said before. Once the first stone falls, it's hard to stop it. We have to stop the first stone.
Very true. Thank you very much. Fernando, un refrán por el Día del Sepsis.
Well, just for as a message for the audience, the early recognition and the time of starting the treatment, they are key, and hemoabsorption may represent an important adjunctive tool that will help us to have a better control of the inflammatory response.
And Sarah?
It's difficult to come to the third one. Probably, yeah, again, the one size does not fit all, but do think about hemoabsorption as soon as you have a septic patient.
My sentence is, if you keep doing things the same way you have done in the past, you will keep having the same results. So we should try to give new options to our patients to decrease mortality and complication in sepsis. With this, I would like to thank everyone for the excellent speeches and Sarah for the discussion, and thank Jaffron for organizing this. It has been a pleasure and a privilege to moderate this session, and hopefully we will have more and more meetings like this in the future to come. Let me take the chance to remind you that in June 2026, we will have in Vicenza, Italy, the Vicenza course on critical care nephrology, CRRT, and large amount of time will be dedicated to hemoabsorption. Thank you very much. Thanks all, and have a wonderful, wonderful World Sepsis Day.
Bye. Thank you.
Thank you, Professor Ronco. Thank you, everyone, to join in the session. Yeah, if you have any free time, so you're welcome to leave your comments and then your feedback to us. And then also I would like to give everyone like a coming up webinar announcement is on the 23rd and 25th of this month. We're gonna have another 2 sessions. Thank you so much for everyone. If you would like to join, please let us know. Thank you.
Thank you.
Thank you.
Bye.
Thank you.